Hello, everyone, and welcome to today's webinar, Reducing Teen Substance Misuse, What Really Works. I'm Tracy McPherson, and I'm going to be your webinar moderator today. I'm a senior research scientist in the Public Health Department at NORC at the University of Chicago. I have provided my email address for you because you are welcome to email me about any of the materials or things that we talk about today, or if you have just general questions about screening and brief intervention or the projects that we're working on as part of the National SBIRT ATTC and the Brief Intervention Group Initiative. This webinar and all webinars in our webinar series this year are produced in partnership with the Brief Intervention Group, or the BIG Initiative, NORC at the University of Chicago, and the National Screening, Brief Intervention, and Referral to Treatment ATTC, or known as the National SBIRT ATTC, which is funded by SAMHSA. All the materials and more about our partnership and each of the organizations is available at the sbirteducation.com website. This webinar is part of our 2016 SBIRT webinar series. I would encourage you to visit the hospital sbirt.webs.com website, and there's a menu option at the top called Webinars, and you can go and see the full lineup. We started in January, and we had already provided a nice overview of SBIRT and many, many resources. That's now on demand. All of the webinars, including that one, are free, and all the materials that we talk about in the PowerPoints are also free and up and available to you. This is our March 9th webinar. We have 2 webinars this month. We have one next month. I hope you will join us for that as well. We're going to be really exploring some new areas in screening and brief intervention this year on gambling and interpersonal violence. You'll see that's going to be coming in June. And also looking at prescription drug abuse and preventing that, looking at prescribing guidelines and brief intervention skills for nurses. Also, we're going to do a little bit this year on something a little different we haven't done before, which I think is really nice. We have a lot of educators that have been joining us, and we're going to talk about how do you integrate motivational interviewing techniques when you're educating the future workforce in conducting brief interventions, and how do you integrate that into the learning curriculum, as well as how do you integrate case studies into curriculum where you're embedding screening and brief intervention education. So I encourage you to check out the lineup, download the flyer, and share that with your colleagues. All of these are going to be made available to you absolutely at no cost, so I hope you'll join us. So access to the materials. This webinar and all materials for all of our webinars are posted at where I was talking about, that webinar tab on our hospitalsbirt.webs.com website. So this particular webinar, same thing. We have a dedicated page. You see the link there. It'll have all the PowerPoints. They're actually already posted for your convenience. Any handouts or materials that we are going to be talking about and referencing today, there are links provided there. That's where the on-demand recording will also be housed, and that will be made available for many months, years to come for your viewing pleasure. So if your colleagues are interested and they aren't able to join us today, please share with them the opportunity to view it on demand. The website also will have the place where you can request a certificate of completion. So you'll be able to request that in the same area on the same page where all the other materials are posted following the webinar. At the end of our webinar today, we're also going to have the opportunity for you to ask questions to our speaker. There's a questions pane, which typically is in the upper right-hand corner, and you can begin typing your questions in there at any time during the webinar. You don't need to wait till the end. We will certainly do our best to address as many of those questions as possible. You'll also have information about our speaker, and if you would like to connect with our speaker directly about what we'll be talking about today, we'll certainly be able to pass some of those messages along to her in case we don't get to your question. And behind the scenes is our technical facilitator, Misty Story. She will be helping you with any logistics or other kinds of questions that you might put into the questions pane. And you're welcome to email her following the webinar if there's something we didn't get to that you need. Also, this is the same person you will be receiving an email from following the webinar, so please look out for those communications from Misty. And our webinar presenter today, I'm very pleased to be able to offer this webinar today. Been really excited about hearing about this report for just a few months now from Trust for America's Health. We have Ann DeBiase, who is the Director of Policy Development at Trust for America's Health, and she's responsible for defining the agenda and the general strategy associated with the organization's goal to create a modernized, accountable public health system and to integrate prevention into a reforming healthcare delivery and financing system. Ann staffed the National Collaborative on Education and Health 2015 Working Group on Substance Misuse Prevention and Early Intervention in Schools. Ann has served in several policy positions in Washington, D.C., and as the president and CEO of the Oak Orchard Community Health Center. She came to Washington, D.C. as a Robert Wood Johnson Health Policy Fellow, working for the U.S. Senate Majority Leader Tom Daschle. For 6 years, Ann served as board chair and treasurer of a faith-based harm reduction nonprofit. So it's my to welcome you, Ann, and thank you so much for sharing today some of the findings that have come out of the report. We are really excited to have you, and so I'm going to turn it over to you.
Thank you, Tracy, and also Misty. I'm delighted to be here to talk with everyone in the audience today about this really critical topic. And, you know, when we look at what's in the news right now around substance use, you know, I agree with the alarm over the increasing number of deaths due to overdoses. But I also believe that preventing substance use disorder in the first place is possible. And I really learned that through the process that Tracy mentioned, the National Collaborative on Education on Health. And I know there's 30 years of science behind this. So I'm so excited to share with you today what I learned through that process and, importantly, the recommendations coming out of our learnings, both at the National Collaborative on Education and Health and at the Trust for America's Health. So, okay. Okay, bear with me. There we go. There we go. Okay, so about the Trust for America's Health, better known as TIFA, in case you're not familiar with us, we are an evidence-based policy and advocacy organization. We're based in Washington, D.C. I think outside the Beltway, we're best known for reports like the one I'm talking to you about today. We produce reports on all kinds of timely public health issues. A lot of folks know us for an annual report we've been doing for the past decade that used to be called F as in Fat. Now it's called the State of Obesity. Like this report, it takes a critical public health issue and rates the states on how they're doing in implementing evidence-based policies. We got interested in substance use prevention because we noticed that overdose deaths were starting to eclipse motor vehicle accidents when we were doing our injury prevention work, and so obviously we realized that this was a huge public health problem. Given that, in 2013 we did a report similar to the one I'm talking to you about today, but it was specific to prescription drug abuse strategies to stop the epidemic. Following that, we got our advocacy arm going and started a coalition on effective prescription opioid policies, or CPOP. And that's co-convened by TIFA, the Community Anti-Drug Coalitions of America, or CADCA, and the Honorable Mary Bono. So obviously this is a bipartisan coalition, and as there's a lot of action in policy circles right now, it's a pretty busy coalition. I mentioned the National Collaborative on Education and Health. That's a group that was formed as an outgrowth of our National Prevention Council. was formed in particular to look at exactly what it said, how education and health can collaborate together to improve student health and increase academic achievement. We formed a working group. That working group met twice. It was funded by the Conrad Hilton Foundation, and I've provided in the chat, you can see Misty posted a copy of the report that really summarizes the deliberations of that working group over the year and the 2 in-person meetings that they had. And that report fed into the report I'm going to go into detail about today, Reducing Teen Substance Misuse, What Really Works. This report was also funded by the Conrad Hilton Foundation, and we'll now go into what it says. So by way of background, I think probably all of you who are in the trenches understand the depths of this problem, maybe more than I do. Nonetheless, I'm going to give you just a little bit of background and data so you can see the perspective that we're coming from in producing the report. So first of all, why focus on teens? Well, as we all know, a significant number of students try alcohol, drugs, or tobacco as teenagers. And importantly, 90% of adults who develop a substance use disorder began using before they were 18. So in terms of prevention, it seems really critical to start early. Oops. Sorry, flipped too fast. More than 65% of students have used alcohol, more than 40% used illegal drugs, and around a quarter used cigarettes at some point before entering or while in high school. And although the past 30-day use rates you see here are actually lowering, the number of teens who regularly misuse or develop substance use disorders has been decreasing. These levels are still too high. It's similar to what we see in obesity, where some of the levels are coming down, but overall, as we know, as a nation, it's still a critical problem. Same is true with drug misuse. And then, as you know, we have an opioid epidemic in this country, as it's being called. Prescription drug abuse is a major problem, and prescription drug overdoses were responsible for more than half of all drug overdose deaths in 2013. That's more than 22,700 fatalities. After marijuana, prescription and over-the-counter medications account for most of the top drugs abused by 12th graders. Prescription opioid dependence is also linked to a rise in heroin use, which has more than doubled among 18 to 25-year-olds in the past decade. And most heroin users were first hooked on prescription opioids. So, what are the consequences? Well, we know the consequences of substance misuse are severe. Substance misuse can have long-term adverse effects on physical and mental health, academic and career attainment, relationships with family and friends, and establishing and being a connected part of a community. As I mentioned, the number of youth drug overdose deaths has grown dramatically over the past 15 years, as you can see from the coloring of these charts of our nation. So, to get to kind of the point of the report, obviously we need to really focus on prevention. As I mentioned, most adults with a substance use disorder began using before they were 18. So, what do we need to do? We need to prevent substance use in the first place. Okay, that's not always going to work, so therefore we need to intervene and provide support earlier. And then we need to view treatment and recovery as a sustained and long-term commitment. For decades, substance misuse strategies really focused on individual willpower to just say no or intervening once a person already has a serious problem. But the evidence shows that if the country is going to maintain a continued downward trend in substance use, it will require a greater emphasis on these 3 strategies. And those are the overall arching recommendations of our report. So, what is a prevention-oriented approach? What we want to do is build positive protective factors and reduce risk factors. That can decrease the chances of tweens and teens initiating, regularly using, or developing an addiction to alcohol and/or drugs. This approach not only lowers the chances for substance misuse, but also has a bigger impact, since similar underlying root causes have been shown to contribute to increased likelihood of poor academic performance, bullying, depression, violence, suicide, unsafe sexual behaviors, and other problems that can emerge during the teen years. So there are so many reasons to be focused on evidence-based interventions that decrease these risk factors and increase these protective factors. So to the report and what really works. What we're going to do is examine the ways that we can move towards a prevention-oriented continuum of care approach to substance misuse, looking at policies and programs that have a high impact for improving the well-being of America's youth. Our report has 10 state policy or program indicators to help advance the 3 goals I reviewed: prevention, early intervention and support, and a continuum of care with sustained treatment and recovery resources. So the 10 indicators are in front of you. I'm going to go through each one of these, and just a note on these indicators. There's of course a lot of things we want to measure, but we do have to have indicators that have data at the state level that hopefully is produced on a regular basis so we can start to track improvement over time. So I'd love to hear in your questions at the end of the session other indicators that you think might be important, and we're happy to look at them, but just to let you know that some of the thinking that goes into selecting the indicators is the practical availability of the data behind them. And you can see in the report, if you'd like, how your state ranks in terms of these indicators. So this chart shows the state rankings. States ranked from having 3 of these policies or programs to having all 10 of these policies or programs. And as we go through, you'll see how many states had each of these policies in place and thus achieved a score for the indicator. I found it very compelling that except for one indicator, all the other 9 had 30 or more states that actually had that policy in place. So it shows we're in a good position where we're moving in the right direction in this country. So the first indicator might not be what you expect: academic achievement. The key finding here is that 35 states have at least an 80% high school graduation rate. So why is this important? Well, we know 20% of students don't graduate from high school, and among lower income students, that rate is even higher. Substance abuse and school dropout are highly correlated and bidirectional. Providing support to students with academic performance concerns or that are missing school and helping to improve the overall school climate can really support academic achievement. Higher academic achievement helps to reduce the risk factors for substance use. So that's the relationship here. Also in the school environment is the second indicator: laws to prevent bullying. Now this is the one indicator that I mentioned that actually have less than 30 states have implemented. Only 20 states have implemented fully comprehensive bullying laws. I think everybody knows what bullying behavior is. You might have experienced it yourself throughout your childhood. Over 20% of students, high school students, report being bullied. I was really surprised at how high that was. And of course, among lesbian, gay, bisexual, transgender youth, that number is even higher. And that contributes to a number of risk factors that might lead to higher substance misuse and other health problems. And of course, we can't forget the prevalence of cyberbullying. So recommended state policy really goes into how you have to base your anti-bullying policies around the same things we would with any other anti-discrimination policy. And so the first bullet specifies anti-bullying policies really have to address a zero-tolerance policy for race, ethnicity, gender, sexual orientation, gender identity, disability, religious beliefs, and other personal attributes. And it should apply on or off campus and including through the use of technology. So there's also efforts to align these zero-tolerance approaches to bullying with effective intervention strategies to address bullying. So in other words, we don't want to swing the pendulum so much in the other direction that we're really using very harsh discipline approaches. Those can also exacerbate the undesired behavior. So there's a balance here that a lot of states have achieved and more states have yet to implement. The next indicator is tobacco use, preventing smoking. So we know this has been decreasing. We're at an all-time low of 5.6% of 12 to 17-year-olds reporting cigarette use in the last month. That is great. Tobacco, however, remains the leading cause of preventable diseases, disability, and death in the U.S. So what can we do about this? Smoke-free laws, that's the indicator here. Whether states have smoke-free laws that prohibit smoking in public places, including restaurants and bars. In addition, there's other policy measures that are very promising, raising the legal age to purchase tobacco products, increasing tobacco taxes to make products more expensive, and limiting sales to minors under 18 years old. The fourth indicator is alcohol use. And what we looked at here is how we can prevent underage alcohol sales. We know that adolescents binge drink. More than 90% of the alcohol that they consume is in the form of binge drinking. And overall, they consume 11% of all alcohol that's consumed in the U.S., quite a bit. And youth who drink alcohol are more likely to experience a range of negative outcomes, from school to social, legal problems, physical problems. They're at higher risk for suicide and homicide. They're more likely to have car crashes and other unintentional injuries, may lead to misuse of other drugs. There's changes in the brain development. We know that brain is still developing until 25 years old. And of course, there's always a chance for death. What works in terms of reducing alcohol use is holding what we call dram shop laws. And 37 states have these dram shop laws. That was a new term for me, so it might be to some of you too. These are laws that hold establishments that sell alcohol to underage customers responsible. So alcohol retailers can be held liable for injuries or damage that are done by customers who are intoxicated after buying their products. Additional policy recommendations that can curtail excessive and underage alcohol misuse are increasing alcohol taxes, similar to cigarettes, maintaining limits on the days and hours of sale of alcohol, and regulating alcohol outlet density in any area. Our next indicator is one that should be pretty familiar to this audience, I hope. This is access to screening, brief intervention, and referral to treatment. So we know that right now, less than half of pediatricians report asking teens about their alcohol and drug use, and fewer than 25% ask about drinking and driving. I think you all know about SBIRT. I probably don't have to tell you that it is an evidence-based, comprehensive approach to early intervention and treatment. It's also a quick, low-cost way to reach teens and young adults that might be engaging in risky behaviors. So what we found here, 32 states and Washington, D.C. have billing codes and fees for screening, brief intervention, and referral to treatment in their public health programs, Medicaid or any private insurance programs the state runs. And this is really important. We obviously can't scale up the use of SBIRT as a screening, brief intervention, and referral to treatment model if we can't sustain it over time. Like any other health screening, there can be access to reimbursement, and Medicaid is a good way to test that case. So having a distinct billing code is really important. It allows for the tracking and delivery of services if it's used. But even with the billing codes, it's not necessarily that we've solved the problem. You still have to get people to provide the service and bill the service. So what we found is there is a return on investment, at least for adult SBIRT services. I know many of you are probably involved in providing SBIRT services to youth, and hopefully you're helping us build the evidence base there. ROI, it's important to note, the return on investment was the 4th largest return on medical investment in any public health program. So after aspirin use, childhood immunizations, and smoking cessation programs. So that might be something that you can use as you're advocating in your state, and hopefully you can use all of this information. Our next indicator is mental health treatment. So we know that as many as 20% of children have a serious debilitating mental disorder, but only 50% of children with mental disorders receive treatment. Only half of kids that need treatment for mental health are receiving it. Many individuals with mental health disorders are at higher risk for substance use, and substance use misuse can lead to or exacerbate mental health disorders. So once again, we have a bidirectional influence here. Toxic stress and traumatic experiences during childhood can increase the risk for social, mental health, behavioral, and cognitive problems, as well as poorer health behavior and physical health and difficulty fulfilling relationships. All of those negative consequences that we reviewed earlier. So we found that for this indicator, 29 states and DC had increased funding for mental health services in fiscal year 2015. That's great. Mental health services and the funding for them, of course, encompass a broad range from professional development and training, which we're doing today, intensive in-home therapy, screenings, access to psychiatric facilities, outpatient treatment, medication-assisted treatment. It's a broad range of services. So the funding for those services is just critical. It does need to be increased. In addition to the funding, other recommendations in the report are to hold public and private insurers and providers accountable for providing appropriate high-quality services and measuring those outcomes, expanding Medicaid with adequate coverage for mental health, and implementing evidence-based effective practices, such as you all do in your daily life. The next indicator we looked at is depression and access to screening for depression. So our finding here was 30 states and Washington have rates of treatment for teens with major depressive episodes at or above 38.1%. So again, moving in the right direction, but wouldn't it be greater if we were above 38.1%? Because 10% of teens, 12 to 17, experienced a major depressive episode in 2013. And yet, only 38.1% of adolescents with a major depressive disorder received any treatment for it. This is starting to sound like a theme, isn't it? Of course, teens with untreated depression are at higher risk to be aggressive, engage in risky behaviors, do poorly in school, even run away. And substance use and depression often interrelate. The most common treatments for depression, of course, are medication and psychotherapy. So increasing the proportions of individuals with a major depressive disorder that get treatment is a really important public health goal. Our next indicator is around drug overdose, what's known as Good Samaritan laws. And we found that 31 states and Washington, D.C. have laws in place to provide a degree of immunity from criminal charges or mitigation of sentencing for an individual seeking help for themselves or others experiencing an overdose. Drug overdose was a leading cause of injury death in 2013, as I told you, which was what led my organization into this exploration of the topic of substance misuse. It exceeded motor vehicle crashes. Over 40,000 drug overdose deaths in the U.S. in 2013. And although many of these deaths could be prevented with quick and appropriate medical treatment, there is fear of arrest or prosecution if people witness an overdose or if they find someone who's overdosed, and that might prevent them from calling 911 or getting the help to use all ends available to us now to reverse the effects of the drug and prevent the overdose death. So the Good Samaritan laws are really designed to encourage people to help when they see an overdose, or to be prepared if they have a loved one who is addicted and at danger of an overdose. And these laws vary widely from state to state. Our next indicator is about prescription drug misuse, about treatment and recovery support. Only about 10% of teens and adults who need treatment for substance disorders get treatment. And you might think we put these indicators in order. And since access to treatment, the story is getting worse and worse as we go along here, from substance use to mental health to prescription drug misuse. Access to affordable treatment is just critical. We know that individuals can overcome substance use disorders and be successful in recovery, but probably not without help. And there's a combination of funds for these services. A lot of federal funds, state funds, local government programs and service, and coverage, of course, through private and public health insurance plans. We're talking here about the range of treatment, from behavioral counseling to family-based approaches and ongoing recovery support and services. Of course, we have seen that treatment is typically most effective when it pairs with medication-assisted treatment, or MAT. The finding here is that 30 states and Washington, D.C. provide Medicaid coverage for all 3 FDA-approved medications for the treatment of painkiller addiction. That was as of 2014. But even for states that do provide coverage, there's still obstacles. States and insurance providers have placed lifetime limits on coverage, which can be problematic. If addiction continues, they might run into those lifetime limits. There's a need for providers to get special authorization under federal law to treat painkiller addiction with controlled substances, which limits the number of providers and the availability of medications and can make it difficult for patients to access treatment. And there's a limit to the number of patients each authorized doctor may treat with drugs. Again, can be a limit to access to treatment. So, indicator number 10 is sentencing reform. And why? Because tough on crime laws, as we know, have done little to deter crime, reduce recidivism, or rehabilitate folks. Rather, they really resulted in a rapid growth in prison, probation, and parole populations, with corresponding increases in our spending in the justice system. And we're harming a whole cadre of youth that could be productive members of society. This is costly. Youth incarceration costs states and local governments as much as $21 billion annually, and there are disparities. Black youth are almost 5 times as likely to be incarcerated as whites, and Latino and American Indian youth are 2 to 3 times more likely to be incarcerated than others. What we found was 31 states and Washington, D.C. have taken action to roll back one-size-fits-all sentencing for nonviolent drug offenses. So reform approaches that we're talking about include expanding judicial discretion by creating safety valve provisions that allow judges to depart from statutorily prescribed mandatory penalties by taking into account certain circumstances or conditions of individuals. Also, limiting automatic sentencing enhancements and repealing or revising mandatory minimum sentences. So, to go into the part of the report that I think is really exciting, and happy to answer questions around the indicators, you can look at the link to the report. We understand there was a lot of traffic, or for whatever reason the website was being difficult to access, so I'd encourage you to access the full report. It is on page 29, where you can find the ranking for your state. In terms of the conclusions and recommendations, as I mentioned, the 3 strategies earlier, the first one is really putting prevention first. What do we need to do to reverse the cycle? We need to start younger, and we need to sustain support throughout youth. So research has shown us really that there are critical junctures in a child's life when they're more susceptible to risky behaviors. Those are at, for example, periods of transition, when they transition through the various stages of their education. Or those periods could be when they have transitions in their family, personal life, such as a divorce or the birth of a new child. The time that child is going through these stages of transition is a particular time when we really have to provide support. So what does that support look like? Well, we need to address the early risk signs. So we actually know from 30 years of studying at NIDA that there are ways to intervene very early in life, that we know what the risk and protective factors are for children as young as in their first years in early childhood. And there are evidence-based programs and two-generation approaches that support parents and families that we can be investing in and really getting some long-term payoff. And what does this look like? Well, hopefully many of you are involved in various collaborations in your communities to improve the health overall of your communities and combat substance misuse. School-based and wider community efforts really need to be integrated. I heard someone say yesterday on the news, takes a village to address these problems. And isn't that true? We also need to prioritize the collection, analysis, and integration of teen health, well-being, and services data to be better able to assess trends and targeted services programs. As we know, oftentimes we work in silos, with behavioral health in one silo and the rest of health in another silo. So these type of multi-sector collaborations can really go a long way towards integrating those various sectors. As I mentioned earlier, a lot of the interventions that we know work early in life also have other beneficial impacts on kids. They're more likely to succeed academically. They're more likely to be physically healthy. They're more likely to have better mental health later on in life, less likely to engage in risky behaviors beyond substance use, such as risky sexual behaviors. So not only do a lot of interventions work to reduce substance use that we know from studying over time, but they have so many other benefits. They're really good investments. But for some reason, they really don't seem to be spreading or scaling up. So what do we need to do to push these interventions forward? And I'm going to pause here and just talk about one or two interventions. And I'm going to sprinkle a couple more through the next couple of slides. So hopefully some of you have heard about something called the good behavior game. The good behavior game, and if anybody's in the report, you can look on page 78 where we give some examples of these evidence-based substance use prevention programs. The good behavior game is implemented in elementary schools, and it's really an educational intervention. That's one thing that's so great about it. It's not something that we're asking teachers to do above and beyond what they need to do to achieve their main goal of academic achievement. It's actually something that helps them with that goal. It's a classroom management program. It helps to teach students to manage their behavior in a very positive way. It reduces aggression, disruptive, and off-task behavior. And teachers just love it. Over the long term, NIDA research shows that it will also reduces the prevalence of smoking, the use of mental health services, and reduces alcohol use, tobacco use, illicit drug use, and suicide attempts. A number of wonderful, wonderful outcomes. And that's just one example. So why don't we have the good behavior game in every elementary school classroom across the country? Well, it turns out we learned through our process with the National Collaborative on Education and Health that it's not as easy as you think. First of all, schools might not know that the good behavior game has benefits far beyond helping the teacher manage the classroom. Even health providers might not know that. I didn't know that before this process, and I wonder how many of us on the phone today knew that. So people need help to identify really what interventions make sense for their communities and target populations given the risk and protective factors and the assets in their communities. What can help there? What can help is having some end-to-end support. So helping communities really assess what their needs are, doing surveys on risk and protective factors, then identifying, based on those risk and protective factors, the profile that in any community, is it the good behavior game, is it the strengthening families program, is it the life skills training program? There's so many different programs that are evidence-based that might be a match for any given community or school. And then they need help implementing those programs. Implementing in a school setting is very different than implementing in a community or a healthcare setting, and schools need help to really implement these programs with fidelity to the model, both so that they'll work and so that we can continue to really build the evidence base. So we need to provide all that training, technical assistance, and access to a learning network of others who are also trying to implement these interventions. We also have to support this, in a coalition approach, because even though some of the examples I'm going to give you are programs that are implemented in schools, schools can't do it alone. They really have to work in coalition with their communities. And then there needs to be money to sustain these programs over time. Some of them are not very expensive at all. They're train-the-trainer programs. Yet you do need the money to put that technical assistance and training in place, the professional development that's needed for the teachers who will implement the program, for example. And I'm going to talk more about this, but we've found that often requires identifying multiple different funding streams and braiding them together to support the program over time, so you're not reliant upon one funding stream. What else is needed? Let me give you an example of what this end-to-end support might look like. Maybe you've heard of the Epicenter in Pennsylvania. It stands for Evidence-Based Prevention and Intervention Support Center. And really what it is a kind of backbone organization that exists at the state level and brings together different sectors that are working on common issues. So in this case, it's a partnership between the Pennsylvania Commission on Crime and Delinquency, the Pennsylvania Department of Human Services, and the Bennett Pierce Prevention Research Center at Penn State. And this Epicenter is really able to do what I just described to you, to help connect the research policy and real-world practice of child and youth development programs. It helps communities assess their needs, provides the technical assistance to help them select evidence-based interventions from a menu of options, and then helps them implement those programs and sustain them over time. It helps them to build the evidence and help them just to improve the program over time, because they provide that learning network and technical assistance and support. So our report advocates for having something like an Epicenter, a support structure in every state. And I want to be clear that these prevention support structures don't have to just be about substance misuse. They can address other prevention interventions as well, because as I mentioned, many of them really harken back to the same risk and protective factors that we can address in childhood. So that makes it a real cost-effective way to get the evidence into action, bottom line. Now, as I mentioned, one of the things that we noticed is, of course, we need sustainability of funding over time to keep programs in place. We've all probably experienced that. But what we noticed in looking at successful and innovative programs is that we really have to weave together these different funding streams. And we know that can be difficult to do, even, for example, if you're getting different funding streams from one agency, like most of us are probably most familiar with Health and Human Services. Even if you're getting funding streams from, say, the Substance Abuse and Mental Health Services Administration, and then maybe from the Administration for Children and Families or the Centers for Disease Control and Prevention. All of these support putting evidence-based prevention practices into place. But you might need to weave all those different funding streams together to really create a sustainable program. And there's a lot that we can do at the federal level to make that easier for local communities. And there's been some efforts on that behalf in the federal government. They have increasingly promoted what they call place-based work, which is really about, bringing together these programs and funding streams locally so that they can work together, and that there's less duplication of efforts and a more filling of gaps. Some of that could be done through a national coordination mechanism, such as the National Prevention Council. That's the group that I mentioned that really set up the National Collaborative on Education and Health and spun it off as a separate entity. The National Prevention Council has 20 agencies and departments working together all around a national prevention strategy, in recognition that, the Housing Agency, Transportation, Department of Education, the military, all of these various agencies have an important stake and a contribution to health. So there should really be ongoing support for this type of backbone organization, or like an epicenter, in every state. And this needs to be supported at the federal level. States also can help to meld these funding streams together to make it easier on local communities, because I think anybody who's run a nonprofit knows it is not easy to have 20 or 30 different sources of funding. So that's what we're talking about here. And what really does that structure look like on the local level? I think that's something we're still exploring and learning about. But one opportunity I want to mention is that when you have a really effective organization that is braiding together various funding streams, usually they are also exploring the opportunities for bringing in funds from non-traditional mechanisms. So that might be, for example, hospital community benefit programs. That's their requirement, hospitals that have, who are nonprofit, to comply with their tax status. So they really need to contribute back to their communities. More and more hospitals, recognizing in their needs assessments that substance abuse is a major issue in their community, are starting to focus some of their attention in their community benefit program to what they can be doing. They could be a big funder of some of these upstream interventions, because eventually they, like the rest of the community, can stand to gain if we can reduce the prevalence of SUD. There's also pay for success programs where investors invest in programs that have some evidence of working to be able to scale those programs up. And if they're successful, then those investors get paid back. There's tapping into sin taxes, taxes on marijuana sales, taxes on cigarette sales, taxes on alcohol sales, and then even bringing together multi-sector stakeholder coalitions that are invested in the health of their community. As you can tell, coalitions is really a theme through this report. Accountable Health Communities is referring to multi-sector stakeholder coalitions that come together to address an issue, be it substance use or something else in their community. And one thing that we're seeing across the country is, while many of these coalitions may have started out, for example, on obesity, eventually they move on to address other priority issues in their communities. So these are just some ideas, and I'm happy to have more conversation in the Q&A about other non-traditional funding mechanisms to really invest in prevention. So to a topic that, again, I think is very familiar to the folks on the call, is how do we really make SBIRT routine practice? That's really important in prevention and early intervention. SBIRT should really be a part of the regular continuum of well-being screenings that we do, starting in early childhood and continuing through youth, not just in the medical setting, but also in school settings and other places where we can reach our target audience of teens. And then thirdly, the last important recommendation, what we can't forget, is having a comprehensive and sustained treatment and recovery support system. So as I mentioned earlier, there really does need to be increased funding support for mental health and substance misuse treatment. And that's why we really thought that was so critical to have as one of our 10 indicators. Only 7.4% of all health spending in the U.S. is devoted to mental health treatment services, and 1% devoted to substance use treatment. That really doesn't seem to be in line with the extent of the issue that we're facing today. Also, part of building that system of treatment and recovery support is addressing the workforce gaps. We know we have major gaps in the workforce, so we need recruitment and incentive programs to increase the workforce, including recruiting and training specialists and counselors who can focus on the treatment needs of youth. We also need to modernize the treatment end of the spectrum to make sure that we're using the latest research for best practices. So in terms of workforce, there's starting to be some alternate models available of looking at different types of peer providers. There may be opportunities for there with appropriate training and standards to really expand the workforce and be able to provide more intervention to more people. So in recapping our goals, and then if I have a couple more minutes before question and answer, I just wanted to review a couple more evidence-based programs with you and point you to an important resource in addition to the two that Misty posted in the chat. Recapping, this report really recommends that we start early and focus on prevention, that we increase support for early intervention, and that we have a sustained treatment and recovery system that can meet the needs of all addicted individuals. So I said I wanted to I ran real fast with the presentation because I was hoping to get a few minutes more there just to give you a little bit about a couple of more evidence-based programs because I know these aren't generally known. The source I would point you to is the National Institute of Drug Abuse's Red Book, NIDA's Red Book. As I understand, they're about to issue a new version of that Red Book, but the version that's currently on their website is a wealth of information. And in general, I wanted to just point to two types of interventions. One is really an intervention system. So the research shows that there's coalition-based programs such as the drug-free communities, communities that care, or what's known as PROSPER, that are those type of support systems that I described when I described the epicenter earlier, that are helping communities bring together a multi-sector stakeholder coalition to address youth substance misuse. They're helping communities to assess their needs through data collection. They are helping communities match the evidence-based practices to the needs of their communities to be sure that we are implementing evidence-based practices. One of my major surprises through this working group process was to find that only about 40% of schools in America do anything around substance use. And those that do, for the most part, don't use evidence-based practices. That means they use practices that aren't evidence-based. Some of those practices are even harmful. So I really think this is a huge area of opportunity, and we do have a lot of evidence to show that programs like Communities That Care and Prosper can not only help communities implement the evidence, but also help to sustain those evidence-based programs over time. So what do I mean when I talk about these evidence-based programs? What I mean are, in addition to the good behavior game, let me give you an example from middle school, because good behavior game was an elementary school intervention, as you would call. Life skills training is a middle and high school booster program. And what this does is really teach kids personal and social skills along with drug resistance skills. So they take a 3-year prevention curriculum for kids in middle school, and they do sessions with them to teach them drug resistance skills and information, self-management skills, and general social skills. It's been tested for 2 decades. It's reduced the prevalence of tobacco, alcohol, and illicit drug use relative to controls by 50 to 87%. And combined with booster sessions, it has reduced the prevalence of substance use long-term by as much as 66%, with benefits in place beyond the high school years. That's pretty amazing. Another example, also in the middle school space, the Strengthening Family Programs. So this also is a program where youth attend sessions to learn certain skills. In this case, parents also attend sessions. And this is often done in collaboration with local schools, cooperative extensions, and others in the community. There's been positive effects shown in longitudinal studies on parents' child management practices, for example, how parents increase their skills at setting standards, monitoring their children, applying consistent discipline, and on parent-child affective quality. In addition, with a 6-year follow-up, one recent study found a delayed initiation of substance use. We've also seen findings related to resistance to peer pressure to use alcohol, reduced affiliation with antisocial peers, and reduced levels of problem behaviors. There's some cost-benefit data for the Strengthening Family Program that shows that for returns of almost $10 for $9.60 for every dollar invested in the Strengthening Families program. And similar economic returns on the good behavior game, they're even higher. I can point you to resources for that too. So I just wanted to enumerate a little bit what we're talking about when we're talking about these evidence-based interventions, because I know it was new learning to me. So with relatively little investment and relatively little time on the part of the school, programs can be implemented that actually have been shown to reduce youth substance use. So let me end there, and hopefully we can have some questions and discussion about what you've heard in the report today. And somebody should type in the chat box and let us know if you've been able to access the report on our website. I thank you so much for your time and attention.
Well, thank you, Anne. That was terrific. Wow, what a terrific overview of a very meaty report. You can dive right into different sections in that report depending on what you're really interested in. It's kind of nice because there's a lot of information on very specific topics, but you really provided a nice overview of the report and highlighting some of those programs. I think that's really, that's important, because many of the folks listening today are maybe using programs. They don't know whether they're effective or not. They've been recommended by somebody. But a lot of times they get passed down, try this, try that. They may not be able to collect evaluation data to know what's working, but it's really nice to get recommendations from those who've gone out and been really researching what does work, what does the evidence say, so people can understand what programs might be something they would be interested in doing, maybe replacing it with something they're currently doing or just trying something new. As you were talking and naming some of these programs, I just wanted to, if people aren't aware, I think many people have heard of SAMHSA's NREP, N-R-E-P-P, or SAMHSA's National of Evidence-Based Programs and Practices. And as you were mentioning some of these, like Strengthening Families and others, if you haven't been to the NREP site in a while, it really has expanded. It has a lot of, it's organized a little differently, so you can actually go in. It's alphabetized. If you want to look at some of the ones that Anne has mentioned, they'll give you a really nice description. There's also a search engine, so if you've heard something today and you want to type that in, it's really nice because it does actually describe some of the programs that you're talking about. So I want to all of that, and I'm going to send Misty a link here that she can post on the NREP, what the NREP link is. It's nrep.samhsa.gov/all programs, and that will give you 393 programs you can search through. So I want to also, we are at a point where I'd like to really open it up for some questions, and just remind folks that in the chat box there's a link there. We've just posted the link to the NREP SAMHSA site, and also to the report. Some folks have asked, just wanting to make sure they know which report you've been referring to, and that is also over in the chat box, Reducing Teen Substance Misuse, What Really Works, and it is on Trust for America's Health website, so you can download a full copy of that. Let me questions about the report that I need to address here, but all of that is available, and you can link to it from the webinar page that we presented earlier, where all the PowerPoints are that you can also download. So let's see, we'll have a couple of questions here. The first question I have is, are you aware of any studies or research in developing this report, or maybe in just your other research that you've been doing around this, on screening, brief intervention, or referral to treatment, or SBIRT, being delivered to a mental health population?
That's a great question. No, I am not, but I do remember hearing about SBIRT being used in places where they were making efforts to integrate primary care and behavioral health. So specifically, I heard about SBIRT being implemented in some health centers settings where they really had well-integrated primary care and behavioral health teams. So I would assume then that, there is a population that, has some mental health issues there, because that's why they have the behavioral health services integrated. But I don't know specific to a mental health setting or population. That's a great question. I bet there's others on the phone that might even work in one of those settings.
Yeah, it is a great question. It's a question I encounter a lot myself, and I appreciate Jerry for asking that question. If there are folks who are on it that want to email us and give us or put something in the chat, we can see if we have time to collect any answers and respond to it. You're certainly welcome to put it in the chat box. So while we wait on that, let me ask you another question. You had several programs that you were mentioning. In the full report, is there a full list of programs?
Well, there's just a couple of examples, really the ones that I reviewed, and those are on page 78 of the report. So it's not a full list, but I think, the NREP reference was an excellent one. There are several registries of evidence-based programs. One way, and there probably is a lot of overlap amongst them, but you also might be able to get some additional hints on other programs. There's a healthy youth development registry database, as well as the Department of Education has its What Works database. So, there's again, these interventions have effects in all these areas, right? The good behavior game helps to improve academic performance, reduce substance use, promote mental health, so that, the evidence on that program you might find in the SAMHSA NREP registry or in the Department of Education's What Works registry or in a healthy youth development registry, etc. Because a lot of these programs cross, have effects in all those areas. And I think that's one reason maybe why it's been more difficult to translate that evidence into action, in that, for example, we would laugh when we were going through the process, what school administrator or principal is going to NIDA's website to look at their Red Book? Likely none, right? That's not where they usually turn for their evidence. So that's part of the challenge here, is to make sure that, all of us can serve really as translators of the evidence to the people that are in the settings where we might implement it. So if we're trying to reach youth, schools are an important setting. There are other important settings as well, but often the people that are running those organizations, they don't receive their professional development in from the same channels where the registries exist.
Mm-hmm. Mm-hmm.
So I would really, I think you were absolutely right in, pointing folks to, the registry. That is so critical. The other resources, like I said, we use the Red Book. There's also another NIDA document that was just released this week, looking at what early childhood interventions will reduce substance use. And the other thing, let's see. Well, I'm trying to think of other resources. Those are probably the best. I found the NIDA Red Book the easiest to read myself. The other thing is you can look at the Communities That Care or Prosper websites, and because those are essentially systems for delivering interventions, they're not interventions themselves, you can start to see some of the evidence-based programs there. So for example, the coalitions that are part of the communities that care system often implement life skills training. And so you can look at those delivery systems, and they can help you understand what are the evidence-based programs. I think that really is the key question, is how to translate what we do know about what works to the people, get it in the hands of people who can actually implement it.
Yeah, exactly. An excellent point. And I've been looking at the second edition of the Red Book, and I guess they call it the Red Book because it's got this big red swirly. On the cover, it say Red Book, but you can tell it's red and it has blue. And I was taking a look just to respond to that person's question. There is actually a list of programs in the table of contents that breaks it down by universal programs like universal prevention, selective programs, indicated programs, and even within there it has subcategories of what would be appropriate for elementary, middle school, high school, and it does that for each sort of level of prevention. So I think that's an excellent resource, and I think what we'll do is add a link to this also to the webinar page so people can link to it there. It's also in your chat box, and we'll work with you to add some additional links to our web page as well for the webinar so that things that you're referencing folks can readily access. So thank you. And I also went back to the SAMHSA NREP page and thinking about, somebody was asking, so where do you start? And if you're looking at within a specific age range, there's actually a way to filter on the NREP site now by specific groups, the younger children, the adolescents, and so forth. So you can, it's almost like an interactive search process, which I think helps people get quicker to where they need. So thanks for sharing those and mentioning those resources.
One additional one, Tracy, is a report that was done by an organization called Transforming Youth Recovery, and their report is called Closing the Gap, an examination of access to best-in-class evidence-based alcohol and other drug prevention programs for K-12 students in the U.S. So that also is I think, a good resource. And what I like about that report is it also gives a very nice overview of the history in our country of our prevention efforts, what has worked and what has not. And I found that very informative. So I think and then it does list the actual evidence-based practices. They have their own criteria, so it might be, a little different than what's in NREP, what's in the Red Book. All of them have some differences, but in addition, they include links to other evidence registries. So the one I was thinking about earlier, that when I mentioned healthy youth development, is called Blueprints for Healthy Youth Development. And the website is www.blueprintsprograms.com. So I think this Closing the Gap report by Transforming Youth Recovery is a handy reference to all the various evidence registries that exist.
Well, that is very helpful. We're going to try to find that as well and make that link available. Thank you so much. Let's see what other questions that we have here. Okay. This one is a little bit longer, so bear with me. Is there information available that might help predict the possible effects on teen substance use when marijuana is legalized in individual states? I think is there data information and there data available that might help predict the possible effects on teen substance use when marijuana is legalized?
Well, that's a great question, and it's a burning question that a lot of us have. So I don't have the answer. I will tell you that the evidence shows that the perception of the risks of marijuana use, the perceptions are decreasing. So kids don't think that marijuana is that risky. And at the same time, the use of marijuana amongst teens is increasing. And when you look at that kind of a graph that shows both of those, it's a little scary because, you know, marijuana use that begins early, like at age 12, can lead to a drop in IQ of 8 points over time. So it is really significant, again, due to that brain development, as with all substances. So that was a burning question. We did not address that question specifically, although we did discuss it as a part of our working group. And the other link provided in the chat is actually the report from the working group, so you can read that yourself. But we didn't address that question specifically. I would be, I would venture to guess that there is research going on so that we can answer those questions, because that's certainly a big concern, just like e-cigarettes are a big concern.
Thank you, Anne. And you know, you mentioned some of these different examples or programs, and there are quite a few. It'd be hard to remember all of them, but just looking at some of the questions we've had, are there any particular programs that you know of, examples that are likely to minimize the impact of teens' increased access to marijuana? Just the programs that prevent marijuana use are really focused on that?
In our process, we didn't examine, or it didn't come up really, programs that were just specific to marijuana use. So, you know, I imagine you have to look at the same risk and protective factors. So, of course, you know, in the adolescent years, you know, a risk factor is having friends who use substances, of course, right? So that would be, programs that teach kids those resistance skills, or how to, shift their social groups to have a peer group of friends that are not using substances. I think would have an effect for marijuana, just like it does for other substances, like, you know, kids who have friends who smoke are more likely to smoke, right? But we didn't look at any programs, or I'm not aware of any, where there's like a restriction in access like you would with alcohol or tobacco sales. But obviously, where marijuana is legalized, there are ways to restrict the sales to minors that would mimic what's done, you know, in alcohol and tobacco now.
And I'm not off the top of my head either. You know, and it may be interesting to look into some of these different resources to see whether there have been really focused on marijuana. I mean, you know, historically you've seen programs focused on alcohol or tobacco, but marijuana has been, it's been used for years, but there's more attention being paid on it, and maybe there is more program development specifically around it. I know there are screening and brief intervention efforts going on, specifically focusing on marijuana with young people, and some preliminary efforts have produced some early evidence suggesting that it may be promising. I think we need more evidence. Like you said, we need to keep studying and finding out.
Yeah, I think it's really critical to shift that trajectory of where kids are, you know, really thinking that the perception of risk is less. I mean, and it's pretty dramatic, the curve in that chart. So, like, the risk perception is dropping rapidly. So I think education is really important. Like, I know I show my teenager that slide about the drop in 8 points in IQ. That's taking a person of, say, average IQ at 50%, and they would go to 30%. You know, so it's a really significant drop, and it's going to affect the rest of your life, clearly. So I'm not sure how much of that education, you know, we in our school systems, we're, you know, lucky if we have physical education, and we're really lucky if we have any type of health class. And because of the pressures, you know, to really teach the Common Core and get to their curriculum, those things that aren't, you know, PE and health are hard to find nowadays, and that's where those things would traditionally be taught. So some schools are trying to weave sex education and education about drugs and other things into their science classes, and that may work in terms of, you know, sex education when you're talking about reproduction in biology, but I'm not sure where they're weaving in the impacts of substances on the developing brain, if they're teaching that in biology or somewhere else. So, you know, there's been a lot of recommendations that, for example, athletic programs are a great place to teach some of these things, since most athletes, you know, have a motivation to take care of their body and have a respect for their coaches. So I would love to see some of the developing evidence on where we can teach about, you know, what the risks are of early and persistent marijuana use.
I agree completely. We still have a few more minutes for questions, and we have a few more. So let me ask you this one. Okay, was there a rationale in focusing the recommendations on programs versus changing community norms and policies? Tobacco reduction efforts have shown that this population-based approach is cost-effective and or more cost-effective and sustainable. So was there a rationale in focusing the recommendations on programs versus changing community norms and policies?
Oh my gosh, I couldn't agree more than that. We are a public health organization, and I couldn't agree more than that. I guess I think it's a really interesting question, and I guess I would see our indicators really as things that do change community norms. So I would love to hear more about that question, because I think that's the idea here, is to change community norms. As I mentioned in the beginning, and to really create policy systems and environmental change that can impact entire populations at once and be lasting over time. It sounds like that's what the question is getting at also. So, you know, for example, sentencing reform is a really good example of that's a major policy change that is a change of a norm that, you know, over time we hope will have an effect. So I would love to, I've focused a lot on programs, just knowing the audience might be in a place where they can work and develop partnerships locally to implement some of these programs, but absolutely the indicators are more focused at a high level on these policy changes. As I mentioned in the beginning, we are, of course, limited by, you know, the ability to have data. So absolutely, I agree with the person who asked the question around tobacco and the impact that changing those community norms has had on tobacco. Absolutely, and I think that's what I'm trying to emphasize here in response to the question about marijuana too. But when we look for indicators, we do have to be practical about having the data to back those up. So these questions are showing, you know, we really don't have the data to show how we can change the norms around some of these things, like marijuana yet, or e-cigarettes, since, you know, that's relatively new. Another good example of that one is really the bullying. That's really an effort to change the norms in schools.
Mm-hmm. Mm-hmm. It's an excellent example. Thank you. Okay, let's see. We have another question here. Okay, this is a little bit different, thinking about telecommunications technologies and smartphones. Okay, so switching gears here a little bit. Do you know of any efforts to explore how telecommunications technologies, such as smartphone-based programs, can be used to scale up prevention and treatment programs and place them in the hands of adolescents?
Oh, wow, that is such a great question too. I don't, but I know this came up recently in work we were doing around sex education. And, you know, there's a lot of research going on in that sector to look at how electronic communication can be used to educate kids, since that's you know, they're really going to the internet for their information about sex anyways, is what the research shows. So shouldn't we at least have, you know, appropriate and, you know, good information really out there for them to access, and really it doesn't exist. So that's such a good question. That could work, of course, for all these substances that we're talking about, but I think there's great opportunity in public health. Generally, we've seen how telecommunications can be used, for example, to educate pregnant women, to have better birth outcomes. So why couldn't it be used to educate youth and have better outcomes around reducing the prevalence of substance use disorders? That's a great question.
Mm-hmm. And I think we hear a lot of terms around digital natives and all these different terms to refer to young people, and they're, I don't know if it's a reliance, but they're certainly they've brought up with a lot of technology, and they're drawn to technology, and for many their lives revolve around technology, and how do we use it effectively. I think we still have a lot of work to do to know what does work, what does engage young people, and we need to evaluate what does work, and I appreciate some of your recommendations around needing that kind of support, whether it's in our foundations or federal agencies and coalitions, to try to do this work, study it, and evaluate it, I think is really important. So I'm certainly interested in that area. If there are folks who are aware of any smartphone technologies that have been studied, and you know, I'd have to look into the NREP program database to see if there is anything in there. There are very few digital types or technology-based programs the last time I reviewed it, but I think they have added some, so it might be good for folks there as well. Okay, let's see. Oh, let's take one more question here. All right. Oh, this person sort of self-describes them as a cynic. Oh, this will be fun. At the risk of sounding a bit cynical, now all practices, quote, practices are called, quote unquote, evidence-based programs. If they are in fact evidence-based, where can we research the evidence to convince ourselves or others that we should adopt these strategies?
Well, I'm a skeptic like that too, and that's why I pointed to the NIDA Red Book, because I feel like, you know, that NIDA funds this research and has for 3 decades, and the Red Book is their attempt to translate that to a more layperson audience. Gosh, you should look at the number of references in our report. There's 365 references for this, like, you know, 80-some page report. So there is a wealth of information. I will also point you to, there's a report from the Institute of Medicine, their work group on, I'm sorry, I'm not going to get the exact name, but on children and families, their board on children and families, had a work group that looked at behavioral health around prevention. And I think the name of that commentary, a report coming out of that, was The Power of Prevention. I think that's also a good resource for looking at what the evidence base is. Of course, when the Institute of Medicine uses the process, they are also always looking at the evidence, as are we. I think any of the resources that Tracy mentioned earlier, the NREP registry and the other registries that are in the Transforming Youth Recovery report, the Department of Education's What Works evidence registries, all of them are pretty rigorous. My understanding of some of them is it's actually really, really difficult to get rated to get into those registries. So hopefully they will point you to the underlying articles so that you can see the data yourself in terms of what, you know, what the research found. The National Institute of Mental Health also has a similar tool on their website where you can go in and search by topic or researcher, and you can actually click on the studies that they've funded and start to look at whatever they've published in the literature. So I also can be a cynic, and I totally agree that we sometimes need to see the data with our own eyes, as I was able to through this process, to really embrace these interventions, because it's true, evidence-based is thrown around a lot, and promising and best practices, and so it can be confusing. But I do think particularly these government registries are super rigorous. So I feel like you can trust that once it's gotten into a government registry, it has met a certain level of evidence that all of us would expect.
I think that is great advice, Anne, and Institute of Medicine and the others that you referenced, and looking at NIDA and NIAAA and SAMHSA and NIMH. I mean, there are, if folks are not familiar with some of those resources, I certainly would encourage you to go there. I mean, those really are the places we would look to for the best evidence and the most advanced science from their clinical trials and the work that they fund. And one of the more recent, for some folks who may not know, Principles of Drug Addiction Treatment, a research-based guide, which is available from NIDA. I think these are the go-to places. So thank you for answering that, and I hope that we help John answer his question and point you in some good directions to review the literature. So we're getting very close to the end of our time. I'm just going to see if there is one more question in here that we might be able to address quickly. We have several questions that all came in right at the same time. How about this one? It's a little different than the others. Is there any data out there or in the report that shows that the return on investment is for youth development, youth-led substance abuse prevention community coalitions?
Yes, there is. And I think one source that I use to look at the cost effectiveness data is the Washington State Public Policy Institute. They do, so it's almost a leg up from getting into these registries, that then in Washington State the Public Policy Institute does research on the actual return on the investment. So even though a program may be effective, are the returns more than the cost? It's an additional question that we can ask, and that's a great question. So that's usually the resource that I use. A lot of these programs have been rated, and some of them have gone up and down over the years based on new studies coming out, so it's a very current source. So the Washington State Public Policy Institute I would definitely recommend for the cost-benefit analysis.
All right, great, Anne. And we have a couple of folks who responded to some of the questions we threw out to our participants. Ken was kind enough to mention and remind me, and I should have remembered this, that OASAS, O-A-S-A-S, so OASAS in New York is pilot testing SBIRT in mental health sites. And Larry says that Kitsap Mental Health in Washington is using SBIRT in mental health settings and using the craft with their clients, and they love the screening tool. And also, I think I saw another response somewhere, and this will help wrap up our session today, but it's nice to see some folks helping us to respond to some of the questions we may not know all the answers to. Let's see. I thought I saw one more. Oh, yes. Well, let's see. I know it was from Brett. Okay, yes. So, Jerry, last response to your question is that yes, there. And I read a webinar called "It's Time to Close the Gap: Implementing Substance Use Screening and Brief Intervention for Adolescents in Mental Health." It's going to be on 30th at 1 Eastern. I encourage you to go to the IRETA, I-R-E-T-A, all capitalized website, search on their webinars, and find that March 30th webinar. All right, so we're going to close our session today, and I just want to thank you so much for this wealth of information and answering these questions. This was a terrific webinar. What a wealth of information. And I look forward to reviewing some other sections of the report I had not reviewed yet. I know others are equally excited to hear this, and they're thanking you for a terrific presentation. I just, in our last moment, want to remind you the PowerPoint slides. If you'd like a certificate of completion, you can link to it from our website. The on-demand recording will also be placed there. We also ask that you complete a very brief evaluation survey that's really critical to being able to bring you this quality education at no cost to you and to continue to support our funding to be able to provide you this quality series. So please complete the evaluation. You will receive a follow-up email if you're attending this live that provides links to all of these things and the survey. If you are going to be viewing this on demand, we ask that you go through the on-demand webinar and at the end you complete the on-demand survey evaluation link. Everything is available on the hospitalsbirt.webs.com website under our webinars tab. So thank you, everyone. I thank you for joining us today, and I just want to remind you to please join our future webinars and download the flyer, share these announcements with your friends, your colleagues, social media, get the word out. It's always free education with very quality presenters. If you have any questions or are interested in some telephonic technical assistance I can provide to you by email or phone, something that triggers a thought or a question in your mind, don't hesitate to contact me. I appreciate everybody attending today. Thank you to all of our partners who have worked with us in partnership to really bring you this series. And again, thank you, Anne, very much, and thank you, Misty, for putting on a terrific webinar today. So thank you so much for joining, and have a great day.
Thank you.